Leukemia originates in the bone marrow and is initially systemic. Lymphoma originates in lymphoid tissue and is initially localized. The etiology remains unclear. Multiple theories exist about oncogene activation, which most likely includes multiple factors. Viruses can suppress immune function or activate oncogenes such as HTLV-I2, V, and HIV-1. Bone marrow damage from radiation, chemicals, and malignancies secondary to cancer treatments is another factor. Some chromosomal abnormalities are diagnostic for leukemic subtypes. For instance, T1517 is diagnostic for acute promyelocytic leukemia. Genetic factors also play a role, with increased incidence in conditions like Down syndrome and Fanconi anemia. Lastly, immune dysfunction, both hereditary and acquired defects in the immune system, is considered a contributing factor. Leukemia and lymphoma can be classified by the stem cell involved and the length of the clinical course. Lymphoproliferative disorders can be acute or chronic, while myeloproliferative disorders can also be acute or chronic. Bone marrow examination is used to aid in diagnosis. Indications include investigation of peripheral blood abnormalities, such as unexplained cytopenias, staging and management of patients with certain lymphomas or solid tumors, and ongoing monitoring of response to therapy in patients with malignancy. Optimal sample for examination includes both the aspirate and core biopsy specimen. The posterior superior iliac crest is most commonly used. Less commonly used are the anterior iliac crest or sternum. The bone marrow is routinely assessed for cellularity, ME ratio, megakaryocyte evaluation, iron stores, and differential. Assessment may also include flow cytometry, cytogenetics, molecular and microbiology testing. Comparison of acute and chronic leukemias. Duration. Acute leukemia survival is weeks to months without treatment. Death is due to infection and bleeding. Chronic leukemia survival is years without treatment. Predominant cell type. In acute leukemia, immature or blast cells predominate. AML has myeloblasts while ALL has lymphoblasts. In chronic leukemia, maturing or mature cells predominate. CML has granulocytes and CLL has lymphocytes. Clinical manifestations and laboratory findings. Acute leukemia has a sudden onset and affects all ages. Common symptoms include weakness and fatigue due to anemia, petechiae and bruising due to thrombocytopenia, fever and infection due to neutropenia, variable leukocyte count, and marrow blasts greater than 20% based on World Health Organization classification, or greater than 30% based on French-American-British classification, with cellularity over 70%. Chronic leukemia is frequently asymptomatic initially and affects adults. Anemia is mild or absent, platelet count is normal to slightly increased, white blood cell count is usually high, and marrow cellularity is over 70%. Both acute and chronic leukemias can present with unexplained weight loss or night sweats, splenomegaly, hepatomegaly, and lymphadenopathy. Treatment chemotherapy used is dependent on the type of leukemia, so proper diagnosis is crucial. Other treatments include radiation, bone marrow or stem cell transplant, and supportive care with transfusions of red blood cells and platelets, antibiotics, and growth factors. French-American-British, FAB, and World Health Organization, WHO classifications. Hematopoietic malignancy classifications. The FAB classification is based on cellular morphology and cytochemical stain results. FAB defines acute leukemia as having greater than 30% bone marrow blasts. The WHO classification is based on cellular morphology and cytochemical stains, but also utilizes information obtained from immunologic probes of cell markers, cytogenetics, molecular abnormalities, and clinical syndrome. WHO defines acute leukemia as having greater than 20% bone marrow blasts. The WHO classification is now the standard for diagnosis, while the FAB classification is easier to use and is still widely taught.